Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmad Umar, and today's topic is tracheostomy. As it is a very long topic, so we will discuss it in two parts. The learning objectives for these presentations is by the end of the presentations, the students should be able to define the tracheostomy, understand its functions, and able to list the indications. There is a little difference between the function and the indication, so one should be able to understand that, and whatever question the student being asked, able to answer that accordingly. Then classify different types of tracheostomy tubes. So these will be covered in the first presentation, part 1, and the part 2 will detailed about the procedure, its post-operative care, post-operative complications, and the process of removing the tracheostomy tube, which is the decannulation. So, definition of tracheostomy is it is a surgical procedure of creating an opening in the anterior wall of the trachea through the neck incision to facilitate airway access and ventilation by placing the tube and converting it into a stoma on the skin surface. So this is basic definition of creating an opening in the neck through the neck in the trachea's anterior wall, and connecting it with exterior through a tube by placing a tube. So the functions, the first and the foremost function is it provides an alternative pathway for breathing. This circumvents any obstruction in the upper airway from lips to the tracheostome or below the level of just below the level of cricoid. So it bypasses the problematic area and provides an alternative pathway. So this is not the normal pathway but an extra pathway for breathing. Then the second is it improves the alveolar ventilation by decreasing the dead space. The normal dead space is around 150 mils, so it decreases it around 30 to 50%. Then it also improves the alveolar ventilation by reducing the resistance to airflow. Third is it protects the airway against the aspiration of the pharyngeal secretions in patients of coma or paralysis, bulbar palsy, etc. And also the aspiration of blood in cases of hemorrhage from the pharynx, larynx, or any maxillofacial injuries. It also helps to remove the tracheobronchial secretions again in those patients who are comatose and unable to cough, and where the cough is painful as in chest injuries. Then fifth function is the tracheobronchial airway can be kept clean of the secretions by repeated suctioning through the tracheostomy. Again, because of the buildup of too much secretions, it helps to remove those secretions and clear up the tracheobronchial airway and avoid the need of repeated bronchoscopy or intubation due to secretions. Any patients who has to be given intermittent positive pressure respiration or ventilation for more than 3 days or 72 hours, I mean on those patients who are on ventilator and has to be remain on it for longer than 3 days, minimum is 3 days, then tracheostomy is a preferred superior to intubation. But again, it depends upon different hospitals. Sometimes we can take it up to 3 weeks. If any patient who has to remain intubated for more than 3 weeks, then we can do tracheostomy, or in some cases they can wait for a week or so, but minimum 3 days is mandatory. After any ideal situation is if any patient has to remain intubated for more than 3 days, tracheostomy is the preferred method. Then last function is as a pathway to give anesthesia. So to administer anesthesia in those patients in which the endotracheal intubation is difficult or not possible, like in nasolaryngopharyngeal growths, where the larynx is not visible due to growth, base of tongue growth, again the area is not visible, or any maxillofacial trauma or limited restricted mouth opening, maxillary fracture, mandibular fracture. These cases, it is the intubation is difficult, so tracheostomy is done to give anesthesia, and in such cases, after uh, the surgical procedure, after 1 day, the tracheostomy can be removed. So now coming to the indications. So the indications are basically subdivided or categorized under three main headings, which are the three R's, like respiratory obstruction, retained secretions, and respiratory insufficiency. But do remember that mentioning these three R's only in case of or in response to indication, the answer will be wrong, because these are the main headings. While tracheostomy indications, you have to mention the name of diseases, which we will see in the later slides. So just mentioning these three R's, it will not suffice. You have to mention the name of diseases, so memorize the diseases, the name of the diseases in which the tracheostomy is performed. And the fourth is again to administer anesthesia. So for the respiratory obstruction, it is further subdivided into 7-8 causes which lead to respiratory or laryngeal obstruction, in which the patient will present with stridor and tracheostomy has to carry it out to restore the airway. So it can be infections, trauma, foreign body in larynx, laryngeal stenosis. The most common under infection is the acute laryngotracheobronchitis, acute epiglottitis, diphtheria, Ludwig's angina, retropharyngeal or the parapharyngeal abscess. For trauma, any trauma above the level of trachea, cut throat strangulation, trauma due to endoscopies, and other reasons. So wherever there is upper airway obstruction, tracheostomy has to be carried out. Then fifth is the any tumor, mainly the malignant, but some benign tumors like recurrent laryngeal papillomatosis, they are benign tumors, but they cover the larynx and can give rise to stridor, so tracheostomy has to be performed. Any condition leading to edema of the larynx due to steam, irritant fumes, gases. So these are a whole list. You can go through them. And like neurological, this is very important. Bilateral abductor or adductor paralysis. Tracheostomy is mandatory. Tetanus, GBS syndrome. This is Guillain-Barré syndrome is one of the most common patients of medical ICUs requiring tracheostomy, and certain congenital anomalies. So you have to remember 6, 7, 8 from these all these causes. Your answer, you can easily give the answer of indications of tracheostomy or structures or diseases visible on indirect laryngoscopy, because many of these diseases you can identify by examining the larynx via indirect laryngoscopy. So this is one of the most important viva and OSCE questions. Then for retained secretions, when the patient is unable to cough, like a comatose or respiratory paralyzed patient, the secretions they build up and can block the airway and despair, or what you can say, uh, give problem for breathing, gives rise to breathing difficulty. So these secretions has to be sucked out, because lower chest secretions they cannot coughed out. So tracheostomy has to be performed for removing the secretions rather than actual breathing, because breathing will improve once these secretions are removed. Then any patient with painful cough like chest injuries, multiple rib fractures, to ease the process of respiration, tracheostomy is done. And cases where there is too much aspiration, again tracheostomy has to be carried out. Then respiratory insufficiency, chronic lung condition, though these are some of the rare causes of performing tracheostomy, but still tracheostomy has to be carried out if these conditions uh, are in advanced stage and leading to severe respiratory problems or respiratory insufficiency. So like in emphysema, chronic bronchitis, bronchiectasis, atelectasis. Then, as I mentioned, those patients who need prolonged intubation or prolonged ventilation, tracheostomy is superior to endotracheal intubation. And to give general anesthesia where intubation is difficult or not possible. Then common indications of tracheostomy in infants and children. In infants, most common are the subglottic hemangioma, subglottic stenosis, laryngeal cyst, glottic web, bilateral vocal cord paralysis, and you can identify these conditions by performing flexible laryngoscopy, because indirect laryngoscopy will not be possible in small children or infants. So flexible pharyngolaryngoscopy will give diagnosis of these patients. And mostly inflammatory or traumatic lesions in children are the acute LTBR, laryngotracheobronchitis, epiglottitis, diphtheria. So the previous one which we mentioned, these are infective conditions more common in the children than in adults. Contraindication, as such, there is no absolute contraindication and none in emergency, but only if there is no consent, then because consent is important, and you can proceed only if the consent is there. Uh, Relative indications, if there is infection at the site, incision site, there is uncorrected bleeding disorder or anatomical distortion like tumor. These relative contraindications are again in the patients who are on ventilator. So once these things are corrected, then you can perform the tracheostomy. And like in this anatomical distortion tumor, the problematic one is the thyroid tumor. So in those cases, ENT full plant surgery uh, is done carried out at the same time uh, in collaboration with general surgeon, or where ENT surgeon they are only performing, then they can do that. So these are some of the problematic areas or contraindications. Then classification of the procedures. So the tracheostomy procedure is classified based on the duration. It may be duration of tube placement. It may be temporary. The tube can be placed there for few days to weeks to months and then remove, or permanent, that it has to be stay there for whole life. Then based on the technique, it can be surgical with full procedure or percutaneous, and based on the level, it may be high, mid, or low tracheostomy. So types of tracheostomy is the emergency tracheostomy. When there is complete or almost complete obstruction, one has to carry out emergency tracheostomy. Again, remember that the most common and easiest way to restore the airway is endotracheal intubation. So only in those patients in which endotracheal intubation is not possible, emergency tracheostomy is carried out. Second is the planned or the elective tracheostomy. Therapeutic is to relieve the respiratory obstruction, to remove secretions and provide assisted ventilation. And prophylactic, as again in patients in which the surgery of tongue or floor of mouth or mandible is done, then temporarily you can perform the tracheostomy, because the site of surgery is coinciding with the endotracheal tube and it can disturb the procedure. So in such cases, tracheostomy is carried out first. So the area of operation should not be hindered with the endotracheal tube. Then permanent tracheostomy in patients who have laryngeal stenosis, subglottic stenosis, bilateral abductor paralysis of vocal cords, any upper airway problem which cannot be corrected easily or not possible to correct it, then or techniques or facilities not available, whatever the reason, in those cases permanent tracheostomy has to be done. Mini tracheostomy, or the mostly known as the cricothyroidotomy, it is carried out in severe emergency when intubation or tracheostomy is not possible. Like any patient where the facility of these both procedures is not there, or to take them to that site, it requires little more time than cricothyroidotomy. Between cricothyroid, on the cricothyroid membrane, you insert with the knife or incision, give incision there and put any tube there, straw there, whatever, to open up the airway, and only reserved for ventilation in emergency situation. But once cricothyroidotomy if carried out, then it should be converted into proper tracheostomy as soon possible. And last is the type is the percutaneous dilatational tracheostomy. There will be placement of tracheostomy tube without direct surgical visualization of the trachea. Only camera or laryngoscope or bronchoscope flexible is preferred. It is attached, is used to monitor the passage of needle. It is passed through the nose or mouth to visualize the passing of the needle through the neck, then guide wire, dilators, and tracheostomy tube insertion. So there is no need to give long incision of 5 centimeter, only 1 centimeter incision, and then through those guide wire is passed and dilator is passed, and then tracheostomy tube can be passed, and everything is monitored via the camera through the bronchoscope. So the anatomical sites, according to the anatomical site, it can be high, mid, or low. High is between the first and second tracheal ring. Remember that never in first, between the cricoid or the first tracheal ring, because it will always give rise to subglottic stenosis due to perichondritis of the cricoid cartilage. Again, why the perichondritis of cricoid cartilage occurs and not the cartilages of trachea? Because the cricoid is a complete ring. So when the infection of those complete ring occurs, so it will give rise to stenosis. High tracheostomy, we only carry out it in carcinoma of larynx because this whole structure has to be removed. This all area, thyroid, and this all area, it has to be removed. So performing it high, and what usually we do, you can either perform the high tracheostomy during total laryngectomy, or you can perform it 1 to 2 days before, 2-3 days before the planned big surgical procedure, but not in any other cases. The normal is the mid tracheostomy is the normal between second and third ring, or third and fourth ring. So ideal is second to fourth ring, anywhere in between this area. This is the incision of choice. And lower one is the below anything incision below fourth ring is the lower tracheostomy, but one has to be careful because it can give rise to injury to major vessels or the apical pleura, especially in small children. If you are low in the neck, then there is many chances of injuring the apical pleura. Now the tracheostomy tubes types, there are different types of tracheostomy tubes which can be classified according to the material: metal, plastic, PVC, and silicone. Then according to design wise, they may be cuffed and uncuffed, fenestrated or non-fenestrated, single or double lumen, or with one with adjustable flange. So the metallic tracheostomy tube is the Fuller's tracheostomy tube and Jackson's. The Fuller, it consists of an outer tube and removable longer inner tube. The inner tube is longer so that any secretions which stuck in the inner tube, it will not block the outer tube. We'll see that in the next slide in the picture. Inner tube is easier to remove and clean. Some of these metallic tubes, they have a speaking valve or a fenestration which helps to which acts as a speaking valve and potentially allowing the air to pass over the vocal cords to enable the speech. Then the Jackson tube, it consists of an obturator with inner and outer cannula. So if you look at this metallic tube, this is the inner, this is the outer. The outer tube has a cleft. The inner tube is longer than the outer tube. So the secretions, crust, if they're stuck here, the inner tube is removed and that is cleaned, and outer tube is spared of those crusts. So this is the fenestration or the speaking valve. So if the person, if they want to speak, then only this speaking valve or this fenestration doesn't mean he starts speaking. He has to put finger on this hole also, so to prevent the leak of air from this hole, and then the air will pass upward through this hole and patient will able to speak. This is the Jackson's tube. This is the obturator and inner cannula and the outer tube. The Portex tube, it can be with or without cuff. This is the cuff and this is without cuff, or it is easily available and most commonly used tracheostomy tubes. Some less commonly available are the one with the two tubes. This is the inner tube and this is the outer tube. This is the cuffed extra. No, these both are inner tubes and this is the outer tube with cuff. Uh, the two tubes are because the patient, when he is on ventilator, you cannot put a fenestrated tube because air will leak and the ventilation or ventilator will not be maintained. So these two tubes are the red one, it contains the fenestration. The outer tube already has fenestration, but this other one, the transparent or white one, it doesn't have any fenestration. So if the patient is on ventilator, you put this tube, so air will not leak. But if the patient is weaned off from the ventilator or want to go home or want to speak, then you put the one with fenestration. Then the Shiley's tube, this is the most sophisticated, decent, you can say, made and well made but costly tube and not easily available. So it can be again curved, uncuffed, fenestrated, non-fenestrated with both inner and outer cannula. This is a pediatric single tube. This is the obturator or guide wire. Then this is adult size fenestrated tube with inner and outer cannula. Again, two types of inner cannulas, one with fenestration, one without fenestration. Fenestration role, as I already mentioned, is act as a speaking valve. Uh, Patient can be sent home. The benefit of using the metallic tube and the tube with inner and outer cannula is that patient can be sent home on these tubes. This is one of the most common viva question which many students they fail to answer. Just giving the answer that those who requiring prolonged uh, sport of the tracheostomy are provided with this inner and outer tube. No, you have to tell them that to the examiner that those patients who have to be sent home from the hospital, because if the patient is in the hospital, then there are other methods to remove the secretions, but only in those patients which has to sent home, they cannot be sent home on single tube of Portex material because they will not able to clean it unless those patients have suction machine in the house, but suction machine is also costly. So instead of sending the patients on a single Protex tracheostomy tube and asking them to purchase a suction machine, patient is placed on the metallic tracheostomy tube or this Chinese one with inner or outer cannula or Protex with inner and outer cannula. The inner cannula patient will remove and clean, uh, and so the secretion will not stuck. And this is non-cuffed single tube. No, this is also in inner and outer, but non-cuffed. So by design, it may be cuffed or non-cuffed. This is the cuff, and there is no cuff here. Uh, Cuff is mandatory for the patients who are on ventilator. It prevents aspiration and air leak, but cuff should be deflated after every 1 hour, 2 hours for 2 to 5 minutes to prevent damage of the pressure of the cuff causing ischemia on the tracheal wall. To prevent that, though now there are low pressure cuff tubes available, so we prefer to use those one. And as mentioned, it is necessary for ventilatory patients and also in immediate post-op period. because patients in the immediate post-op period, there is chances of aspiration. So we inflate the cuff for 6 to 12 hours and then permanently deflate. And in between that, it should be deflated for 5 minutes after every hour. Non-cuffed tubes are used in conscious patients where because if you use immediately after the procedure, there will be risk of aspiration. But in conscious patient, the aspiration chance is less. And as mentioned, the cuff should not remain inflated for long. Then the fenestrated or the non-fenestrated, these are the fenestration. It may be single fenestration or multiple fenestrations, which are present at the area of maximum curvature. These holes help in speech production and also weaning from the tracheostomy. It can, but the problem is because there is an opening and edge there, so continuous irritation can give rise to granulation formation in the mucosa of the trachea. There is limited use in ventilator patients and immediate post-op period because as I mentioned, if you're using a fenestrated tube, then the inner tube should be non-fenestrated and that is cuff one. But usually we don't prefer the fenestrated tube in the immediate post-op and on ventilator patients. So this is the non-fenestrated cuffed tracheostomy tube. So the tube, according to the cannula, it may be either single cannula or the double cannula. The single cannula tubes are mainly the Protex tubes. They are used routinely but require regular suctioning via a suction machine. For the double cannula, these are the two cannula. The inner cannula, it has a lock and you just twist it the clockwise, it will be locked. These tubes have outer and inner cannula. The inner cannula is longer than the outer cannula, or the tip of the inner tube. It projects a few millimeters beyond the distal end of the main tube, as I have shown in the metallic one. This means that the secretions collect in the inner tube and which is removed and cleaned and replaced without disruption to the patient or their airway. So the inner tube is removed 2 to 3 times a day and cleaned, while outer tube is removed after every 1 to 2 days and then it is cleaned. But important step is just after the procedure for first 4-5 days or up till the 1 week, outer tube should never be removed because the tract has not been formed till that time, and removing the outer tube, there are many chances that the tracheostomy side will be closed and the patient will become apneic or unable to breathe. So one has to be take care, only remove the outer tube when the tract has been formed properly, which takes around 5 to 7 days. Then the tube with a speaking valve and those with adjustable flanks, they are very rarely used, but mainly the other ones they are used commonly. So this is all for the first part of the tracheostomy. In the next part, we'll discuss in more detail. Thank you for your cooperation and listening.